Hello. Thank you. I was going to say thank you for all the organizers to inviting me. My name is Shneel Pathak. I'm a caregiver, advocate, and entrepreneur. And I'll begin with explaining why I started my company. My late wife, Heng, was diagnosed at 36 with metastasized lung cancer. She was a non-smoker and avid runner. The oncologist told her her life will be measured in months, but she was an outlier and lived for over 5 years. I'll tell you how the democratization of data empowered us to beat the status quo. After her third line failed, cancer progressed, and the prognosis was poor. Our request for a tumor biomarker test was denied by Alberta Health Services. Determined, we openly shared our profile on the internet because for my wife, life trumps privacy. A lung cancer blogger read our story and advised the test can be done in Boston. The results from Boston proved she qualified for the latest lung cancer drug that's available in Canada. 1 month later, the MRI showed a complete response to the brain metastasis. 2 months later, I took this photo of her in Bali. She passed away in November 2017, but it was 18 months after starting the drug. Now looking back, AHS denied the test for the gene sequencing test, but what frustrates me is that they had the capability, they had the asset, they had the test, but they wouldn't give us access to it. We couldn't pay for it. So it's quite frustrating. So we had to leave the country for it. And that's a common theme which I found with these outliers, is that they have to leave Canada to get either tests or treatments. Now the key thing about data is when you have data, you're empowered. And when you're empowered, you could self-advocate. And I started Health Analytics Solutions because I want the outliers of today to be the standard of tomorrow. The software service provides tools to journal your health and turn the data into meaningful use. We focus on patient-derived information, and we're not a PHR. As we scale, I believe our platform can provide patient-reported outcomes to advance research and influence health policy. The services is offered direct to patients because of barriers we faced with the health system, and I'll go through some of those barriers. So first off, just our value proposition. We provide a single place to journal your health treatment plans, symptoms, metrics, and you can store your documents in a virtual binder, because often patients carry around with a big paper binder of their data. Doctors, there's a University of Florida study showed that doctors give you 11 seconds to tell your story. Right? So we provided the technology such that you could come up with a patient report so you spend less time on your history and more time on your treatment plan. And the way you communicate depends on what you want to communicate. So you could either do it through a list, you could do photos, or you could do a graph. And then because we offer a service as a platform, you could actually grant caregivers access to it, and it's available globally, which means then, let's say the scenario in our trials was what they liked is the fact that an adult child could be living in Toronto, wants to understand how mom's doing in Calgary. Well, they could log in and they actually could see the information. They could actually play back the recording. They could take notes. They could put questions there. So there's more empowerment amongst the family, and to me, that's value. Now, from a policy standpoint, it's architected to get real-world evidence, and it's anonymized data. We could separate the private data from the anonymized data. You could do standardized health surveys, and then researchers were interested in our application because they found that often research is done from a top-down approach with a specific data set that they want. Well, you could also capture a bottom-up approach of that data. So we believe that patients should be collaborators with research, not just information givers. And lastly, I think in our discussions with value-based healthcare, we talk about the system, we talk about physicians, but there's also a need for patients and us to be accountable for our own health. And we do touch about that, but we don't really have tools to do that, and this is what we offer, is a tool to be accountable for your own health and your own journey. Now, the other features that we offer is it's configurable for any disease or comorbidity. So our competitors do single-purpose apps, right, that reside on one phone. That, to me, is kind of an old-school method of offering a service. We have one application available on either tablet, computer, or mobile. It doesn't matter. You don't have to download any information, and we can configure for any disease. Purposely, we did that because your body's not siloed, so why should we be? It's scalable, as I mentioned, geographically and by users, and we're not a custodian of health data. We're considered a consumer app just focusing on health, which means it's a very different take on if a health authority builds an app for patients. And then lastly, what we call is Match.com for patients, but what we found is there's precision medicine, and what you're getting is precision patients, where people are seeking out people with exact same profile as them, down to the genetic profile if you, let's say you have cancer. And so this actually, and so what we do is we were going to be developing is a matching system, so you could actually match people with the same profile as you, because there's power in numbers, basically. This is also, I think, aligns with Scott Wallace's talk about segmentation of patients. I'll just go and give you some examples of the application and then talk about the barriers. So this is this is on your iPhone. So this is the therapy management module, and it'll list all your therapies that you've gone through. We are agnostic if it's complementary or conventional therapies. It doesn't matter. We let you track what you think is best and what you deem as a therapy. So, for example, let's say you had a surgery, you could take photos of discharge papers, take some notes, you log it in here. 3 years later, if you need to find out what the details were, you could just do a keyword search for it. The other example where we used the application for my wife was when we had chemotherapy, and we were fine-tuning the infusion pump for the right flow rates and flush rates, etc. And nobody keeps that information, right? So we were able to take photos of that, type in some information, and so we could recall it for the next visit, right? It's about empowering yourself with your own data. And so we have the tool where you can take photos of any paper or anything you want, and then put the metadata so it becomes searchable. And the other thing we could do is, because we have a list of prescriptions and complementary medicine, it's just easy to be current on when you're providing that information. We have a virtual binder. So often on our system, the way you communicate to a patient is by paper. It could be conventional medicine, it could be or complementary practice. It's all by paper. So now you could actually upload the PDF, you could take photos of it, as I mentioned, but some real world examples is the second example there, which is the lab requisition. So we were in the ER, and they needed to do labs, and I asked, well, why don't you do the oncology labs as well? You know, it's usually we do it the following day. He said, I'd love to, but I don't have the requisition. So I pulled it up on my phone. He was able to do it. The benefit is my wife saved saved getting blood work done. I saved the drive to the labs, and the system saved money from reducing the duplication of tests. So the third one is actually more personal. That's a personal directive. So this is how fragmented, and as all you know how our system is. Tom Baker Cancer Center is 50 meters away from Foothills Emergency. They don't talk, the systems don't talk to each other. So we were told, you know, fill out your personal directive, you know, given her case, gave it to Tom Baker, but we were also told that if you go to the ER, most likely they will not be able to access it. So what good is that? So the burden comes to me, because she doesn't have the capacity to make decisions, then it's me as the spouse. And so at least I have a peace of mind that it's on this app. And this app is not just available on my phone if I lost it. You can log in from any device that has internet access. So I won't go into the details, but as I mentioned before, that you have 11 seconds to tell your story at the office. And so once we have structured data, you actually could come up with a report, and this is a patient preparation report. Because the key things which you want to convey is what's your issue, what you've been taking, who you've seen, and any other data. And so this is actually it's conformed to answer those questions, so you spend less time on your history and more time on your treatment plan. That's the goal. You have very finite time with the doctor, you want to be very effective. But also, you could list photos too, because sometimes photos are better to narrate your story than verbal, and you also could graph. And an example here is we were graphing, so a lot of patients, I find, is they mimic they track metrics, what the doctor is tracking, and they start graphing it on Excel. And so we were graphing the tumor markers, and we saw a spike up of the tumor markers. So we told our doctor, he agreed that that's suspicious, so he moved forward the CT scan, and that validated our assumption. Now, we validated the assumption that the progression occurred before symptoms happened, which means we were proactive rather than reactive. So here's the barriers. So first off, patients lack knowledge in health technology and have no money. I find our system is configured for the lowest common denominator of a patient, which is that. And that does a disservice to people who actually fit that profile. Because people like me who don't fit that profile are pigeonholed in that. And actually that's a disservice. Then we got into the morals, right? Public is good, private is bad, right? Which is kind of what we talked about in our table there. So I don't think our healthcare system could survive without for-profit private companies. If you look at it, if you dispense a drug, it's a private company. A Band-Aid, same thing. The Cancer Center in Calgary is a multi-billion-dollar, it's built by the project is built basically by for-profit companies. Okay? We are a for-profit company, not ashamed of saying that. And the irony is this, if for us to get access to innovation technology as well as government grants, we have to declare ourselves a for-profit. But then we go to healthcare, we get this moral card put up. So I think it's more of protecting the status quo and preventing innovation than really the debate about public versus private. The famous question, what about privacy? So my background is in computer engineering. I spent about 15 years with sensitive data, putting it in systems. Technology, privacy and security of technology have less to do, privacy and security of data have less to do with technology and more to do with people, processes, and priority. It's organizational behavior that contributes to the weakness of data and data breaches, right? That's why you could do banking online, right? There's a lot of private data there. And commercialize first. That's where we struggle. We struggle with having somebody to be a first mover. And that's one thing of my call and my ask here is we need first movers. We're testing the application now, but we want to ramp up our trial. We need people who would want to, foundations who would want to use our application and prove that this actually offers benefit. But going to the health system, they don't want to be a first mover, and what happens with innovative companies is we end up leaving. We pivot to the States. And out of the 5 companies in Calgary that I know, digital health companies, 3 now service outside of Canada. They have big contracts in US and Japan, and I think the third one is also looking elsewhere. There's only 2, myself and another one that are still persistent. And this is why, because of these barriers, we've pivoted and not really selling to the health authority, we're going direct to patients. Because there's a need there, there's a demand, and there's a willing to pay for something that's reasonable that offers value. Some feedback that we've gotten. So we did some analysis through W21C, which is a group out of University of Calgary. So there's the attitude by some providers that they don't trust patient-reported data. And so to me, I have no comment to that. If you don't trust patient-reported data, then why are you serving patients? Because all your data really comes from an individual. Now, we did get some positive feedback that they see the benefits of this application for patients to educate, communicate, to reduce anxiety, but they wouldn't use it in their practice, right? So that variable, that the practitioner there's too much of a spectrum between people who are championing this and then people who are very pessimistic. So we're really not going to practitioners, we're going to the people again as a way to influence practice and how medical practice is conducted. I'll just be quick here. We did trial the application, and now we're improving the application, then we're getting ready for another trial. So we have people with chronic disease and cancer, and sometimes both using the application. And so we have received positive feedback, and the friction points is what we're trying to correct. And so here's my ask, as I mentioned. We want to partner with disease foundations or patient support programs to offer the service. and we were looking for help to facilitate a 100-person trial of the application. We do have interest from a researcher who wants to use the application to test quality of life improvements for prostate cancer, but that's around 6 months down the road, but we want to work sooner than that, so we're looking for a call for partners. Thank you.
Good afternoon. That's a hard act to follow. Congratulations, Shanil. That's awesome stuff to channel that kind of life story into some productive work. Thank you for sharing that. Good afternoon. My name is Rodney Burns. I'm the Chief Information Officer and the Privacy Officer. I drew the short stick at the Alliance for Healthier Communities. We just rebranded. We used to be known as the Association of Ontario Health Centers. So on Hoodle, I'm a user. I did post a paper that I'm going to refer to. I spent the last 3 years working on my fellowship with the Canadian College for Health Leaders and wrote leadership guidance on a consumer digital health strategy. So if I make leaps in logic or concepts, it's all there. You can pull it down. When you can't sleep some night, have a read. So who are we? At the end of the day, the Alliance for Healthier Communities is really trying to ensure that we're providing very effective service delivery to those that face barriers to good health. So we target about 22% of the population in Ontario. It's about 100 organizations. We serve about 6% of primary care in the province. So we're pretty small on the radar screen, but we do great things. At the end of the day, my work as the CIO is performance management and the techie stuff, the information management side of it, in helping our clinicians really be as effective as possible in providing primary care to the clients that they serve. The goal for me, one of my great influences in life is the father of quality improvement, Dr. Edward Deming. And he's known for saying, without data, you're just another person with an opinion. Right? So show me the evidence at the end of the day. So my work is about creating the evidence and the data to help inform decision making. My focus is at the consumer end today. The provider side, the organizations, the researchers, they got lots of structure. We need to be thinking about transforming the healthcare system from the perspective of the individual that's actually looking to receive services. The vision of our organization, best possible health and well-being. And it's important that we talk about well-being. This is not just a medical model. This does address social determinants of health. In fact, our research has shown that as much as poverty is a contributor to poor health, social isolation is as impactful. So how do we start changing the narrative such that our clinicians are actually thinking about how many friends do you have that you can rely on if you had a need? So our organizations now ask that question to incoming clients, and anybody that says that they don't have 5 people that they can turn to, family or friends, they get wraparound services to connect them. That sense of belonging becomes very powerful, whether it's a seniors group that they create those social connections with. We brought the former ADM of Primary Care Branch to Sudbury Community Health Center last summer, and he walked into a room about this size, and there was 40 85-year-old seniors, 85 plus, and they were all line dancing. He's going, oh my God, primary care. There's no primary care going on. These people are dancing. And at the end of the day, he selected 3 to ask, what are you doing here? We didn't pick them, he picked them. And Hazel, he said, why are you here line dancing? She goes, oh my God, if I wasn't able to come here 3 times a week to see George and Louise, I'd be dead. Every one of those 85-year-old seniors was living at home independently. And oh, by the way, if I need to get my medications adjusted, I can go see my NP. It was an afterthought. It's about thinking about the individual holistically, and those social needs often outweigh the medical needs. So, like I said, about 100 organizations, community health centers, Aboriginal health access centers, and for me, the democratization of data, bang on. How do we use that as the currency of the health system? Just like its lifeblood at the end of the day. and really make that a meaningful artifact for the provision of services. It's not just what I do to you, services I give you clinically. Here's your information, here's how to interpret it. Can I educate you as a provider on what this information means? Will it influence your behaviors? Does it change the way you act? Will it improve outcomes? So that's the value chain that we work on trying to measure in the work that we do. This is our strat plan, and the coolest thing about this is every one of the organizations in my association all line up to this. I used to be the regional CIO for 6 hospitals and one of the former community care access centers. I could never get 2 of them to agree on anything. I have 100 organizations all buying in. That's powerful. So to me, this is something Leah Stevenson taught me around the concept of collective impact. You can get 100 voices all saying the same message, you can move mountains. And this is what we've done. So in the details on this slide deck, you'll see number 3, demonstrate the value and impact of the model of health and well-being on the improved health outcomes and experience of people and communities. That's where I live. I measure that. I help our organizations measure that. So these are the models. To be a member of our organization, you have to endorse at the board level one of these 2 models. They are complementary. The one on the left is the model of health and well-being. In it is social justice, health equity, the concept of community development. These are concepts not traditionally practiced by primary care practices in the province of Ontario. It goes broader. The one on the right is actually a translation of that model into a culturally appropriate equivalent for our Indigenous communities. This is their interpretation of it, so it follows and aligns to the medicine wheel, but a lot of the same measures are used to measure both. Okay? Out of this, we have a few epidemiologist-type researchers that helped develop over 100+ indicators to measure the effectiveness of these models. And in that evaluation framework, those indicators are made available within the electronic medical record for our clinicians to capture systematically, and then every night, the systems send data into a data warehouse that can be used for benchmarking, comparison. It creates actually a population health data set, and it's all codified, which makes the research community drool because it's high quality data. I know tomorrow we're seeing CIHI present, and as an aside, we've been working with them quite a bit to inform their EMR content standard. And 5 years ago, they wanted us to collect 160 data elements. They figured out that's not feasible because it's too much burden on clinicians. So it's down to 45. I was able to cut a year's worth of that data for CIHI to use on COPD patients out of our business intelligence warehouse, did not disrupt one clinician. And we were able to achieve a story that said, yep, codified primary care data is fit for use in Canada. Right? So this is the art of the possible. So I'm very excited about that. For me, those models derive an information management strategy. And this is, you can see the model in the middle, and the previous Liberal government, patients first was the big strategy and moniker. There was 4 pillars: access, connect, inform, and protect. Every one of these initiatives in these clouds hit on at least 4 or 3 of these key areas. So we had lots of alignment with provincial funders and agencies. What I'll draw your attention to is in the top corner here. This is, I only have one X chromosome, so don't hate me. I'm a simple guy. Get electronic, share your data with me as a patient, as a person as well. Promote collaboration with me as well as the team. Keep your eye on the ball, improve health. It's not rocket science, right? Pretty straightforward, but easier said than done. So at the end of the day, that's what guides the work we do in each of these domains. As I said, the big focus for me right now is that consumer health space. My premise in my paper is until we start to reorient investment and capacity building into communities for using digital capabilities like what Shaniel is talking about, we're not going to change the fundamental cost paradigm. There's a lot of avoidable healthcare costs that could be dropped out of the system and reallocated to needs, right, at the end of the day. But we have to engage individuals as a meaningful member of their own care team. So what have we been able to achieve? Value realization from the work that we do. we were able to get about a third more advanced use of our EMR than the average EMR user in the province of Ontario using Ontario MD's own scoring methodology. Good thing. We were able to improve clinical performance through use of our BI tool. How? We brought back trend data right back to the clinician in real time that said, you know what? You're hitting on all cylinders when it comes to cancer screening rates. We've had some of our organizations actually achieve the 95th percentile for breast screening, for FOBT, for cervical cancer. The provincial average is 40%. It's bringing insights and awareness to the clinicians to go, I've got people in my practice that I need to get screened. That's good practice, right? We also have a lot of work in health promotion and community development, and just by visualizing the practice and the uptake, we saw a 7-fold increase in that little application that my team supports in being able to document, evaluate, and share community development activities. Democratic engagement, get out and vote. It's important for your neighborhood. Have a sense of ownership. If you're familiar with the Canadian Index of Well-Being, we actually use 3 of those epidemiologically validated measures in our EMR. Self-reported physical health, self-reported mental health, and sense of belonging. So when CIHI looked at our data, we now can see where individuals are actually capturing results against those 3, which I think is really exciting stuff. That's not medically clinical, but socially super relevant. The average client seen in our member centers, because we target those that have barriers, tend to be way more complex. And with the ICES, IC/ES, I always call it ICES, Institute for Clinical and Evaluative Sciences, they published a study that shows the average client seen is 27% more complex than the average client seen in a family health team. So family health teams see the worried well, healthy families. We see those that really face those barriers tend to have 10 to 12 comorbid conditions, mental health, addictions, homelessness, etc. Right? So very difficult to manage clients. They're not difficult clients, difficult to help manage, right? We also do a lot of work around safe consumption, harm reduction, because not everybody is a model to fit a disease pattern. It's whatever they define as optimal health outcome from their perspective. And that's the narrative I want to hear more of, rather than, well, here's the traditional arc of your disease state. We're also doing really innovative stuff with coaching from the National Health Service in the UK. We're doing a social prescribing pilot, and I heard somebody mention it earlier today. So we have actual special prescription pads that our docs and NPs use. If they write a script for exercise and they take it to the local gym, they get a 50% reduction in fees. They can get good food. They can get a reduction in fresh food. What was the other? Oh, you can get a free bus token. So you can get support at employment services to help get a job if that's what's been prescribed to you. So these projects are just starting now, but at the end of the day, I think they're going to have huge impact on managing these individuals. And at the end, we do measure client satisfaction, and consistently our organizations are hearing that they're hitting on the right pieces for their clients based on their satisfaction. This is a busy slide, but this is the BI tool that we use, that we give to our clinicians. You don't have to know the details of it, but at the end of the day, it's real-time data. They can drill down. It gets to the competitive nature of clinicians because they can compare to each other in the organization, in similar organizations, in the LIN, anywhere in the province. So they can find opportunities, call their colleague and go, hey, how are you doing that? And we've seen huge improvements in that performance just by returning their data directly to them. Thank you. I'll stop there for now.
It's hard to be a presenter when you find these 2 presentations so intriguing. I was trying to concentrate on what I was going to say, but I was listening more to you. My name is Kathy Bernard. I think most of you know me. I'm not here today to talk about Save Your Skin Foundation, of which I'm the founder, or about being the longest melanoma survivor in North America as of today. Woo woo. Yay. But I want to talk to you a little bit about a project that Save Your Skin was invited to 3 years ago in Europe. It's called AllCan. And I might kind of jump around. We started as All Can. We have now moved the name to All Can International, only because we're starting to set up sort of subsets across the world globally. So we have all heard concerns about the sustainability of the healthcare system. These questions are important in the face of growing pressures on budgets and the changing demographics. At the same time, there is evidence of waste and inefficiency across health systems. This is always the case in cancer care. When policymakers address budget pressures by focusing on cost containment, this can actually create inefficiencies, limit care, and ultimately worsen patients' experiences. If you want a truly centered health system, we must look at patients' experiences and identify potential improvements and reduce the waste. So today I want to introduce you to All Can. It's an international initiative that Save Your Skin has been part of for the past 3 years. I would also like to talk a little bit about how we would like to introduce, hopefully, this initiative into Canada. And also sort of want to summarize how All Can Canada could possibly be a precursor to value-based healthcare in Canada. Okay. Oh. Okay. All Can was established to engage policymakers on the need to improve the efficiency of cancer care by focusing on better outcomes for patients and focusing our resources on what matters most to patients. We are an international multi-stakeholder initiative set up to identify ways to optimize the efficiency of cancer care by focusing on improving outcomes for patients. Our vision is a world in which patients are always at the heart of sustainable care. Our aim is to identify ways we can optimize the use of our resource in cancer care. All Can International is truly multi-stakeholder. I didn't put up the slide with all the partners that are part of that, but I would suggest that maybe after the presentation that you could maybe take a look at the All Can International website. I noticed that Scott talked this morning about ICHOM. ICHOM is a very valuable partner in All Can International, and they've done some incredible work with us, so be good to take a look at their website. Across the spectrum of cancer care, there are a variety of opportunities to improve efficiencies and reduce the waste. 20% of spending is currently estimated to be wasted on ineffective treatment and care. It is estimated that countries that reduce this wastage can add up to 2 years of life expectancy to a patient. Beyond the cost considerations, waste and inefficiency can negatively impact patients' outcomes. Lost time, canceled appointments, and unnecessary procedures profoundly impact patients' quality of life. In cancer, the need to improve efficiency is especially urgent. 2.5 million people are diagnosed every year, and its prevalence is increasing with our aging population. What makes All Can unique? We work with all stakeholders: patients, healthcare professionals, payers, and private sector companies. We focus on improving the entire cancer pathway from diagnosis to end-of-life care, rehabilitation, and survivorship. We focus on action. We are committed to helping embed meaningful and evidence-based change. We start with the patient insights. This is the basis of our research and objectives, improving outcomes for our patients. Improving efficiency is not simply a cost-cutting exercise. It is a means of focusing resources on what matters most to patients. To do that, we need to make better use of the mountains of health data that are routinely collected. We must invest in the collection of meaningful data and use them to track variations in care and whether care matches the patient's needs. We all have a responsibility and an interest in improving the efficiency of cancer care. Improving efficiency is ultimately about systemic change, and this comes from our policymakers. Again, we believe there are opportunities to improve efficiency across the entire cancer pathway by focusing on what matters most to us, the patient, and by using our resources as effectively as possible. We are at the forefront of innovation and engagement. Our pioneering research is laying the foundation for tackling systemic problems of waste and inefficiency, ultimately contributing to the sustainability of cancer care. In the last year, the Alcan International family has now moved into national initiatives. Australia, Belgium, Canada, Germany, Italy, Poland, Spain, Sweden, Switzerland, and the UK have since been established. And in development now are Austria, Denmark, Greece, Japan, Norway, and the US. There was interest around Alcan Canada a couple years ago. When I was out doing my GR policy work, I would always give our HTA a little bit of an update on what I was doing at the Alcan International level, and there was some interest there. But we were a little nervous on how we would bring a project like this into Canada because our health system is significantly different than Germany, Australia, et cetera, et cetera. So we thought, let's give it a try. We call it the discovery phase. So we realize that inefficiency and waste are very large concepts that don't mean the same thing to everyone. We needed to define what that included and identify our focus. But because Canada has 14 health systems, 13 provinces as territories, and a national system, that made it even harder for us to really start to discuss where we needed to start. So we started a small core team of people within our organization with strong project management principles to guide the planning and execution of the work. We also relied heavily on Save Your Skin's existing network of pharmaceutical industry partners, physicians, and patient advocacy group relationships to maximize the efficiency of our outreach to these groups. So our approach in the Alcan Canada discovery phase, and I am going to say discovery phase because we're still discovering, was to gauge the inefficiencies and waste within our Canadian healthcare system by conducting surveys and one-on-one interviews with multi-stakeholders. We have completed our environmental scans, which took 6 months, and we deployed our first pre-meeting survey to our pharmaceutical partners. From this, we have updated our consolidation list of inefficiencies and created a database of physicians and patient groups that were suggested to us. We are currently in the process of collecting data from physicians and patient groups, ensuring they are sent to a comprehensive list of oncologists and patient groups across all types of cancers. We are hoping to execute roundtables, develop a report, hopefully build a steering committee, and maybe a round table or a round map mid-next year. But for those who know me, I'm kind of a big thinker. I think it might be 2020. We are stating, oh, sorry, I took notes from somebody else, sorry. So I want to talk a little bit about a patient survey that was done, and it was actually done by Alcan International. It was a global patient survey. The survey will be completed next month, and I'm going to talk about that in a little bit in the next slide because we compared it to Canada, Europe, and the UK, and I think you'll find it really interesting what some of the feedback was and how similar our needs are literally across the globe. But I just wanted to show you a couple of the top responses that we have gotten to the patient survey, the pharms survey, the physician survey, and the patient group survey to date. And these, I'm sorry, the arrows are pointing to each of the responses, but they really don't correlate. So what we were finding in those surveys were long waits for initial diagnosis, including diagnostic services and misdiagnosis, delays, duplication, and miscommunications in drug approval process, we all know that, resulting in patients without timely access to new treatments, inadequate access across the country. We heard inadequate medical records, information systems resulting in delays and inefficient care for patients, and of course lack of access to psychosocial support for patients. So those were the top 4 that we've heard so far in every survey that we have sent out. So I wanted to show this slide. This is the international survey that was done, and it's comparing Canada, Poland, and UK. And if you look at the 3 top concerns or inefficiencies that we're seeing across the globe, they're actually very similar. Well, they're identical. The only difference is the percentages. Now, the study will be closing at the end of this month. From that, All-Can International will be putting together a report that will be available for anybody who would like to take a look at it. It'll be on Save Your Skin's website, but it'll also be helping sort of direct us in where we're moving in the future with All-Can Canada. So, how does All-Can fit back with value-based healthcare? And I think this is really a summary of the workshop we all just did. And I think from my table, there was a lot of discussion around inefficiencies and waste and how that equates back to value-based healthcare systems. So I think there's a real correlation here, how that looks moving forward. I'm hoping that's a discussion that we'll all be able to have. As you know, value-based healthcare is all about increasing value for patients, which is an All-Can Canada objective. Value is the quality of patient outcomes related to cost or relative to cost. Eliminating waste and reducing healthcare inefficiency is a necessary step to realize cost savings and an opportunity to improve the quality of care a patient receives. The principle of value-based healthcare, or one of them, is that competition is centered on medical conditions over the cycle of care. In value-based healthcare approach, the dollars opened up by the cost savings realized by All-Can Canada could be redirected to other areas of oncology to contribute to improved care that would in turn optimize patient outcomes. So, if you'd like to know anything else about All-Can International, we've done a policy report, we've done some incredible work. We're finding that sometimes we start with the smallest project, and it's probably one of the biggest cost savings, believe that or not. There'll be some examples of some of the great projects that have been done through All-Can International. If you think All-Can Canada is something you would like to discuss, please, contact myself or Louise or somebody from the Drug Pricing Policy Summit Committee, and we can answer your questions. Thank you.
Okay. Does anybody have any questions for our three speakers? We had some diverse and interesting examples of value-based healthcare, lots of great information.
So my name is Michelle. I'm a recent master's graduate in clinical pharmacology from U of T. I actually have a question for Shanil, in regards to that Match.com concept that you mentioned for analytics. So being able to identify patients with a similar profile as a means of segmentation. So given that this is a patient-facing application, can you just further expand on how this feature is going to be used in clinical practice, maybe also in the context of data privacy as well?
Sure. In terms of the Match.com feature, when you register, you put in your profile, and that profile could be quite granular. So once you have the profile there, the system in the back end can actually match people, but not disclose the personal information unless you offer it. And that's how. Now, the whole concept is people are going on the internet and finding other people. And so what we want to do is not develop a community, but help you steer to communities of people or pools of people that are like-minded. Yeah, that's what we're doing. But in terms of the clinical side, we haven't looked at that for Match.com. I won't be calling it Match.com because I know that's trademark. The concept.
I think there's already a Match.com and it's not data.
Yeah, I know.
All right. Another question up front here? Two up front here. That's right.
Thanks for all the great presentations, very informative. My question is for Shanil. The algorithms that you're using in your application, do you think you will be able to predict future themes surrounding certain diagnoses or medical conditions?
In terms of predictive technology, no. Well, in the sense that there's not really technology limitations. We have to be very careful with Health Canada in terms of what we predict, right? This is not a predictive tool. And so it's there to pay attention or give notice to historical or present data. So, but we, yeah, that's, sorry.
Can I ask another
Yeah.
question really quickly? there's a huge disconnect between facilities, but a lot of patients have now accessibility to their health records. Are you wanting to leverage that information through your application?
In the future, we will. And so, yeah, there's a lot of patient portals. But here's the challenge is that how many people in this room have lived the same city throughout their life, right? Hardly anybody does. And so, I think we have one hand. Okay. But the only way to guarantee that you have a complete file, I guess your personal health data file, is if it belongs to you. That's the only way to, I think, guarantee it, right? And so what we want to do is you have the ability to actually pull that data from the portal and put it into, like, let's say, the therapy module if you want. And you could have a repository of that information. Eventually, we are actually pairing up. We just spoke yesterday to a Boston-based company called InterSystems, and they do health data management. If anybody's heard of Epic, underneath Epic is InterSystems. Once we use their technology in the future, we'll be able to stitch together our data with the health hospital system. Because what we want to do in the future is you get the objective data of the hospital system and the subjective data of the patient, you stitch it together, you have a more holistic view. So that's the direction we're going, but we're just not there yet.
Okay.
Thank you very much for all those 3 presentations. For me, they just say we can do it. I mean, that's the bottom line is, you know, it's the think big, act small, don't wait. That, to me, that just makes all the sense in the world. And what I love also, of course, is that we're completely different disciplines, different stakeholders in the system, but together, stitched together, it just makes so much sense. So I guess my question is, this one is mainly for Rodney. I love your, I love the way you work, but I'm wondering why all the doctors and the health clinics in Ontario aren't following your system. What do you think are the challenges there?
So it's a great question. I didn't spend time describing what differentiates our clinicians. Every clinician in our organization is salaried. There's no fee for service. They don't own the practice. They don't own the patients. They make less money than if they were fee for service, but they have a very strong commitment to health equity, social justice. They believe in the organization's mission. So these clinicians are of a common mind. And I can give you an example. About 7 years ago, I really agitated with the ministry to give access to what was then called the drug profile viewer in the province of Ontario to see just that limited little bit of drug data that they held at the ministry to primary care, because it was only available in hospitals originally. And at the time I was a hospital CIO, I saw the impact of, there's a couple docs here. 2 most important pieces of data, drugs and medication, or labs, right? That's what they make their clinical decisions on. As soon as you can actually show what kind of meds somebody's on, especially if not everybody remembers what they're on. And if I can go in and see what you're on, that's a great asset. So we finally got approval for 20 of our centers, not all of them. They just wanted to get rid of me. 20 of them to pilot access to the drug profile viewer. We've talked a little bit here about privacy and security. Some of our docs refused to use the solution because their patients didn't realize what they had access to about those patients. So think about it from a social justice point of view. So then I spent the next year creating materials, and I did my own research. And what I found out was the ministry had advertised that the DPV, the Drug Profile Viewer, was going to be made available in hospitals in the Globe and Mail and on the CBC. Our clients don't read the Globe, and they don't speak English, and they don't listen to CBC. So we created a whole set of brochures and education materials in 12 different languages that could be used with clients to say, this is what I can get on you. Are you okay with it? And as soon as they felt that they had consent, they went into it. So it's a different mindset in the clinicians that work in our organizations. Some of them have come from fee-for-service and private practice. They don't want to worry about overhead and setting up an office. They want some life balance, and they like the idea of the mission of the organizations to treat those that face barriers. So there's that motivation really helps drive us forward in terms of what differentiates our organizations from the other 90% of primary care in the province. We are funded through the ministry, through the local health integration networks. We're the only part of primary care that is fully accountable to the LHINs. So I produce, in fact, the community health centers are the only primary care, the only sector in Ontario's healthcare system to make electronic performance dashboards available to the LHINs in real time. So there's no manual paper reporting quarterly to the LHINs, like the hospitals can't even do that. The CHCs have done it. So that dashboard I showed you is one glimpse. So a performance analyst in a LHIN can say, who's like my CHC maybe out in Kenora or Cornwall, and how are they doing? So using evidence to drive performance and discussions about performance improvement. And we've had the organizations say to me that when it comes to a BI tool, the industry will say, if you're within plus or minus 5% of data accuracy versus what's in the EMR, you're good enough. It's a business intelligence tool. My executive director said, nope, not good enough. You gotta be within 3% error margin. And we've achieved it and have the evidence to show that. So there's very high confidence in the use of that data for performance measurement and management. So at the end of the day, BERT is considered the source of truth. It's not the source of the data, the EMR is. So when a clinician goes, oh, that doesn't look right, it's gotta be wrong. Nope, you have to go and figure it out with your data management folks, what you're doing wrong in the EMR because it's not coming over properly. And it's just accountability for the whole life cycle of data and having dialogue about the data to describe their practice. And once they go, yep, that's me, they live by it. It's amazing to see how that influences the way they work.
Why can't hospitals do that?
Oh, they can.
Why aren't hospitals doing that?
Because I don't want to.
That's a long story. There's a lot of
time.
You know what? At the end of the day, this is a bigger issue, and we're talking about systemic things right here. The system does not incent standardization to that degree. Primary care, the community sector, is even less standardized than hospital data. You know, CIHI pulls data out of the hospitals for inpatient stays, outpatient stays. It's highly structured that way. You got to go to the next level of detail to say we need to be able to do performance comparisons between organizations with like programs. So in the province of Ontario, the hospitals have started this health-based allocation methodology to incent hospitals to serve the catchment population given its needs. This is in the right direction of value-based healthcare. If that methodology was fully applied in the hospital sector today, some hospitals would lose upwards of 30% of their funding. So government has capped it and said, we're gonna phase it in, so you're only risking 1%. But it's enough to start them thinking, okay, what is it my population needs, and do I have the services in my organization's offerings to meet that population? So, you know what? Turning a ship doesn't happen overnight, right? It takes time. Too bad it's taken this long, but it is what it is. And these are big, complex structures that are incented by perverse policy frameworks that need to evolve to include a focus on digital health services and performance data, right? So organizations like Health Quality Ontario is pushing, you know, and Cancer Care Ontario is pushing the concept of patient-reported experience and outcome measures rather than how many hips did you do? How many knees did you do? How long are you staying in the bed? These are important parts of the story, but it's not the goal of improving health. That's not what improves the health. What's the health outcome? So slowly, it's not rocket science, but slowly we're moving in that direction in all parts of the system.
Okay, I think we have one more question back here. Two more. Okay.
To Chanel, I just wanted to ask about having the platform to be able to put in our information as a patient. What we're also missing, though, from a PCN's area is we're missing the dentist and we're missing the optician. We're missing the dermatologist surgeon who works in a private practice and I'm not getting cross cancer filling in these forms either and making them available. So it comes down to the patient, or it comes down to the caregiver to be able to get that information and then pull it together. But there's a huge gap there, because particularly for pituitary patients, they can be diagnosed by the dentist or by the optician much sooner than a GP. And I'm talking 20 years sooner. I'd like to be able to put those sort of details into my personal records as well.
So the solution is actually agnostic to the provider. The whole problem is that we faced is that the patient is the hub for information exchange between providers, right? We're the ones who broker that information, especially between the hospital, conventional medicine, and outside. And so right now, the simplest tool we found is that, it is the responsibility of the patient to ask. Let's say you go to your optometrist and you ask for your details, but you could take a photo of it and you put the metadata or some data saying this is my optometrist, this is the notes, and you actually put it into the module, and then you could do a search for it and you could pull it up. Eventually you'll be able to forward it, but we have nobody to forward it because we have more of a fax-based system than an electronic-based system, so we have no recipient, but eventually you'll be able to do that. But it doesn't matter who the provider is, you could actually enter the information, because that's the whole goal, is that collect all your information, which most people are doing, but they're putting it in a paper binder. Now you could digitize it, and your caregiver could do that process for you as well. Yeah.
Can I just add one comment to that? I have a mom in long-term care, and I think once a patient enters long-term care, there's a huge void there as well. The information is very difficult to obtain. It's very dysfunctional. Depending on who you ask, the outcome of a test, you may get a different answer. It doesn't appear they capture the information. So I'm just pointing out that there's a void in long-term care as well from an information perspective. Yeah.
Thank you. I think we have one question up here. Yeah.
Thank you for the presentation. It's really great to see that there are measuring of data at different levels, not just the government, but also patient group, and also a lot of patient group getting together. My question is on standardize of data measurement and data integration, because there's a lot of there are many different organizations who are collecting different sets of data, whether it's from patient group and also from the government level as well. So when you look at data collection, how do you see this data integration come about, especially when we talked about looking at a patient's full cycle of care, and we're also looking at determinants of health. So we're not measuring just one aspect of that data measurement, but also throughout the disease condition or the life cycle.
Can I take a crack at that?
Yeah.
So when you plug your lamp into the socket, do you think about what frequency the electricity is running at? Is it at 110 volts? No. You shouldn't have to, as a patient, worry about this, right? This is what I do. That's where all the gray comes from.
I'm getting there.
So there are standards that are not emerging, are almost pretty mature. It's getting the system to adopt. So classification systems for interoperability, frameworks for sharing data. The kicker that I've not seen done well yet is presentation of that data in an efficient way for the provider or the carer that needs to see it. How do I filter for what I need and get through what I don't? So if I'm a surgeon, I don't need to see the social works notes, right? Yes and no. I'd love to see somebody treat me holistically and actually see my whole world, but you know what? All I want to know is this. How do I get to this? Because if it's hard to get to, I'm not going to use it, right? So there are data standards of interoperability. The province of Ontario, Canada Health Infoways, and many of the provincial jurisdictions are adopting these standards to be able to share data and then present it in a meaningful way. That's the simplest I can describe it. But there's not a lot of solutions out there presenting that data as richly to be able to say, I'm going to turn the dial and focus my question on what was the last HbA1c results? Can I see that without having to go through a billion clicks? But it's coming. The standards are there.
Part of us partnering with the company in Boston is to have out-of-box standards. So we will have HL7 standard, fire standard, and interoperability. It's actually interoperability in the States. Like when I went down to their conference, is leaps ahead. Especially with the companies like Epic and InterSystems, where they have data lakes, and they're actually coming up with these connectors to actually connect pools of data together. And once you connect into that pool, you get access to that data. And they've taken care of the privacy and security issues. So they're much more advanced. I would say Alberta will soon be similar just because they've adopted a similar technology, which is Epic.
Okay. Thank you very much. This has been a really rich session, lots of good questions, so we appreciate you being here with us. Thank you very much.